Hello, everyone, and welcome to a very special episode. This is our first sponsored video podcast, and what better topic to start with than the very elusive multi-specialty recruitment assessment, the MSRA, which we know for many candidates over the years is often a big bedbug in the sense that it's a critical component of the application. It's often something that in terms of preparation, there's a lot of resources, there's a lot of strategies that other trainees who have got into specialty would advocate. So it often becomes very elusive, very challenging to really get to grips with. So we thought, what better topic than to start with, and no better person to answer these questions than Dr. Mahibur Rahman. So please, if you don't mind, Dr. Mahibur Rahman, please introduce yourself for our audience.
Well, first of all, Mohammed, thank you very much for inviting me. It's a pleasure to join you on this podcast. So my name is Mahibur Rahman. I'm a portfolio GP. So what that means is I'm a GP with multiple roles. And I think this is increasingly popular. So my clinical roles, I'm a partner in my own practice. I have held various other roles. At the moment, I cover 2 community detox units. That's one of my special interests. But up until recently, the last 7 years, I was one of the lead GPs at a secure unit for women with significant mental health illness. So they had a psych team that looked after the psych. Myself and one other GP, we would deal with all of the primary care and preventative stuff. And then over the years, I've worked in a prison setting. I've worked with the military as a civilian medical practitioner, doing medicals for people going into the army. And the rest of my roles, non-clinical, are mainly based in medical education. So I used to be an examiner and invigilator for the GMC. I'm on the author panel for the prescribing safety assessment, which a lot of your listeners will have done when they were either finishing medical school in F1. Sometimes people do it. I'm on the examiner panel for Liverpool Medical School for their OSCEs, and I'm a consultant in medical education. So the bulk of my time now is spent as medical director of EMedica, sort of helping people pass their exams at different levels to progress their careers.
No, that's amazing, and I definitely appreciate portfolio careers are something a lot of my GP colleagues are now exploring, working alongside their more traditional roles, these non-traditional roles. It's good to see another fellow Liverpool examiner support. So if you see us in the OSCEs, you can say hi. You may not get brownie points, but at least you can say hello. Whenever I saw you on the podcast. So before we get into the nitty-gritty about strategies for the MSRA, let's take it a step back. Can you give us an overview of the history of the MSRA? When was it first introduced? And for a lot of our audience, they want to kind of understand what's the rationale behind this exam as part of the recruitment process.
So it's a great question. So it was first piloted back in 2006, and then it was introduced for GP training in 2007. And the reason that it came about is that prior to the MSRA, like when I was applying to get into GP training, so I did my GP training 2004 to 2007. So when I was getting in, they were just developing like a national recruitment. Prior to that, each deanery used to just recruit locally. And so when I did it, the first stage, there were actually a series of essay questions. So you would, and what people used to have these for foundation for a period of years, what they call white space questions. So they ask you to write an essay, half a page each question, but they're like 7 or 8 questions. So things like, can you describe a situation where you had to deal with a stressful encounter at work? What happened? What was your involvement? What did you learn from it? And then you'd describe it and talk about your learning and reflection. Or things like, can you describe a situation where you had to demonstrate good teamwork or leadership, or looking at some of the attributes. Now, one of the issues was, and I think this is compounded even more now with more and more people applying, but as there were more people applying, if you imagine each person writing 7 sort of half-page essays, each of those had to be marked by hand, and the people marking it were senior doctors. They were either sort of GP trainers or consultants involved in the deanery. And so they're all people who, by and large, were working full-time in very busy roles in their clinical role. And because of the short time for the recruitment window, with thousands of people applying for GP training, they just couldn't get through finding enough clinician time to do the marking. The other issue was that marking essays is very subjective. So sometimes someone would, get a low mark and they'd appeal. It'd be remarked by someone else who didn't see the marks from the first person, and they come with very different marks. It has to be marked by a human. It couldn't be machine marked. So they wanted to move away from that to something that could be marked by machine, that could be more objective, and that they were hoping would give sort of some kind of correlation to are they likely to succeed in training. And that's where they came up with, okay, let's have like a standardized exam that everyone sits. That's machine marked. And in those days, actually, it was initially like a pencil and paper. You'd fill in the little blobs and then it was marked by a machine rather than, now it's computerized. There's been several changes with the MSRA over the years. So that was the rationale, is that they wanted to move away from essays where it's subjective and it cannot be marked by a machine. And sometimes, if someone's good at writing essays, that might just mean their English language is great and they're good at writing essays. It might not mean that they necessarily are going to be good at the job. And that's where they wanted to move away from that. And one of the things, half of the paper is the SJTs. Now, SJTs are relatively new in medicine. Outside of medicine, they've been used for a really long time. And they still use it for things like, officer training, senior levels. The police use it, for example. In America, the FBI use it. The civil service use it. And they followed the first few cohorts of GP trainees that did the new exam. And the SJT was a better indicator of are they going to successfully complete training, get CCT, pass MRCGP, compared to the clinical. And so that was one of the reasons I think that other specialties started to look at. So that's the background.
Wow. So, no, I think that's really good context, because I think a lot of applicants just think this was made out of thin air and just imposed upon everyone in the course of a year. I had no idea it was used, the SJT in particular was used like FBI, police. That's really insightful. So it started off in GP recruitment. It was identified as showing, in terms of evidence base, that it had a better indication of who would progress through GP recruitment and the specialty postgraduate exams that you have to do as part of GP training. So as part of the 2024 recruitment cycle, what specialties are using it as part of their own recruitment process beyond GP?
So I think you meant the 2025 recruitment cycle, because although they're applying now, but it's just for 2025 entry.
Applicant, yeah.
So since those days in 2007, it's been expanded to a lot more specialties using it, but specialties use it in different ways. So, for example, GP, psychiatry, child and adolescent mental health service, these use it as, at the moment, the only thing to rank candidates. So 100% of your rank and what determines if you get an offer or not and where that offer is for GP, psychiatry, and CAMS is based on MSRA. Now, this isn't how it always was. Previously, GP, psychiatry, CAMS, they used to use it as part of the rank. The rest was from, like GP had a selection center. So you do like communication skills assessment with like simulated patient, a colleague discussion, and there was like a essay paper. Psychiatry used to have like a portfolio station and an interview. During COVID, there were issues around having lots of people in one room doing all these simulations and moving around and so on. So that they decided just to base it on MSRA. And since then, they've sort of stuck with it, which I think is a shame. I think those things added something, assessing someone's ability to communicate well, their consultation skills, because there was an element of that both in psychiatry. As part of the interview, one of the stations was a simulated patient. I think, those are good things to see who's got a commitment to the specialty, who's got aptitude for some of the other things. Okay. But they now only use it. Beyond that, lots of specialties. So obstetrics, emergency medicine, neurosurgery, community sexual and reproductive health, anesthetics, ACSS, CST, so core surgical training, only recently started a few years ago. And then, of course, we're here on RadCast, so clinical radiology and nuclear medicine. Both have been using it for some time, and ophthalmology. So these are all the different specialties that use it, but they all use it in slightly different ways.
Yeah, and of course, with radiology this year, the 24-25 application cycle, they've said, for those of you listening, that it's no longer counted towards your final rank. Yes, it will be used to shortlist you, which has been common across several years. But in previous years, it also contributed towards your final rank. This year is the first year where they've said it will be used to basically determine if you get an interview, but thereafter it will be 60% of your rank will come from your interview and 40% will come from your actual portfolio. But I do agree with you, Mahib, in the sense that this reliance on the MSRA for certain specialties has kind of removed this element of the assessors getting to know the candidate, saying, okay, you do have these additional skills which would make you very suitable for general practice, which can kind of help your application. Now, of course, the majority of those listening in or tuning into probably any MSRA-related educational resource want to know, okay, how can I get a step ahead of my colleagues, those that I'm competing with? So what is the current format of the MSRA? Any specific changes that have occurred this year that the audience and those who are sitting the exam should be aware of?
Great. So if I go through the format, there's no change to the format this year compared to last year. The main changes are to, number one, how some specialties are using it. So you already mentioned radiologists change from that it was used previously to shortlist, but then the score carried over and made up a proportion of your final rank. This year, clinical radiology, nuclear medicine, and ophthalmology are just using it as shortlisting tools. And then 100% of your rank will be based on portfolio and interview, i.e. this is just to get you to that interview. After that, it doesn't actually matter. Most of the other specialties, it carries over. So like I mentioned, GP, psychiatry, CAMS, it's all of it. Things like obstetrics, it's a third. That's a change. It used to be a quarter. Emergency medicine, neurosurgery, emergency medicine is 40%. Neurosurgery, it's part of the shortlisting score. The rest is self-assessment. And then it carries over and forms a very small proportion, and so on. So, that's one change, is how they're using it. The other main change is competition. And I think that you probably, especially for radiology, have seen this, that if I look at the data over the last 3 years, radiology has gone from 6.2 applicants per post in 2022 to this last year, 2024, 11.9. So basically a doubling from 6 to 1 roughly to 12 to 1. What that means is the score you need to get shortlisted has increased significantly. So a few years ago, you might have got an interview for radiology with a score in the sort of 530s. Last year, the cutoff was about 555. Now, if the competition continues to increase with more and more people applying, it's quite possible this coming year, even 560 might not be enough. So I think that's one of the big things is to be aware of, is know the level of competition, because someone might have a huge commitment to radiology. They might have a great portfolio. They've, written papers, presented, maybe done lots of quality improvement projects, full cycle, showed an impact, done various tasters, put all that effort in. But if you don't get a good enough score in MSRA, no one's going to see that, unfortunately. Just not going to get that chance to shine and show all of that. Whereas as long as you can get a score good enough to get there, now all of that is what matters, which I think, especially for radiology, I think it's a good thing that they're using it to shortlist rather than it carrying on and playing a big proportion. That I think those other things are much more important. But you need that great score. I think that's probably one of the big things. And similar things have happened in other specialties, that like GPs also pretty much doubled over a period of 3 to 4 years. A lot of people sometimes will apply to more than one specialty. And I think one of the things I would say about that is it's fine to have a backup. Sometimes people think, if I apply to 6 things, I've got more chance. I would say actually it doesn't work that way, because while the MSRA is common to all specialties, they might use it in different ways, but the exam's the same.
Yeah.
Because what things are looked at in a portfolio and what's going to be asked at interview and how you practice and prepare for the interview is very different. Someone that applied to lots of things, if you imagine, you might spread yourself a bit thin. If you're trying to apply and practice for 6 different types of interview, you might find that you do okay in all of them. Whereas, let's say you're just focusing on 1 or 2, you can really spend that time preparing for the interview phase and really shine, because, that's really, really important in terms of getting an offer. So in terms of the format, though, so there's 2 papers. The first paper is always the professional dilemma paper. That's the SJT paper. That's the formal name of it. That lasts 95 minutes. And in that time, you'll be asked to answer 50 situational judgment test questions. About half of them are section 1 questions. So these are ranking. You get a scenario, you got to rank things from best to worst. And about half are what we call selection or multiple choice questions. So there's a scenario, there's 8 options. You pick 3 that go together to sort of address the scenario. Now, although there's 50 questions, only 42 carry marks. 8 questions in every SJT paper are worthless. Now, they don't look any different. They won't have a little asterisk or anything. You won't know which are the ones that are there. They're there basically to develop new questions to add into the bank for next year and the year after. So you have to take all 50 seriously, and it can be quite time pressured. Then there's a 5-minute gap, and the clinical paper is 75 minutes with 97 questions, only 86 carry marks. So there's 11 questions again for research purposes to develop the bank. They don't look any different. They carry no marks though. So you've got to take all 97 seriously. And so that's the format of the paper. Now, whether you're sitting it for radiology or GP or core surgical training, the curriculum is the same for all specialties. Okay, so the exam, if you like, curriculum is the same. The format is the same. It's not like because you're sitting for radiology, you're going to get different types of questions more suited to a radiology candidate. Curriculum is the same for everyone. It's a broad clinical curriculum. And then the SJT is more testing against 3 specific attributes. So what they're looking for is, do you demonstrate positives or negatives for empathy and sensitivity, professional integrity, coping with pressure, and a good working knowledge, of course, of GMC ethical guidance. So that's the format.
Fine. No, I think you've hit 2 points which I just want to reiterate to our audience. This first one is the competition ratios. Like, me and Mahib don't have a crystal ball, but we do have years of seeing trends because Mahib's very deep into the MSRA, GP recruitment. Obviously, RadCast, we've seen radiology, and the amount of interest going into both specialties is significant. And often what we find, talking about the second point, is this: I will apply for this and that and this and that. Is that often there is an element of applying to multiple specialties. And I always tell applicants, if you give 50% to 5 things, expect 50% of the results, because you really can't be like, okay, I'm going to get ready for a quite intense CST interview and a quite intense radiology interview and try and develop sufficiently detailed portfolios for both. There will be big holes in your achievements, which you could have plugged if you spent 100% of time, but because you're giving a scattergun approach, you often end up really just shooting yourself in the foot. So when you do apply for multiple specialties, try and do it strategically, try and do it sensibly, and don't really overstretch yourself, because you do have to, for example, especially if you're applying things like academic clinical fellowships, write the white space answers, and that's eating into your revision time for this exam. So try and be strategic and don't really shoot yourself in the foot. So you mentioned the 2 components, Mahib. Let's break it down one by one. What strategy would you advise for applicants for each element? And based upon not only your experience of supporting others going through the MSRA, but your own experience of like seeing candidates perform based upon the advice you give.
Okay, so I think for the clinical paper, is mostly about knowledge and a little bit about exam technique. Whereas the SJT is almost the opposite. It's mostly exam technique, and there is a little bit of knowledge to do with GMC guidance and so on. So for the clinical, I would say that understanding what are the curriculum headings, and then just allowing enough time. I think, you could sort of put people into 3 categories in terms of when they start preparing. So there's people that know, okay, I want to apply for this. They've looked at the person's specification. They've looked at, what was published from last year, because sometimes they do, like this year, make changes very close, but they know roughly, okay, applications open in November. I've got to get my portfolio ready by this date. The MSRA is usually around here. Like this year, there is one other big change to that, is that the timing of the exam. Because the recruitment office and sort of HEE are expecting a really large number of candidates based on how many people applied in the last round, they've actually said that they're planning capacity for 2 sittings for round 1. So normally the exam's the first 2 weeks of January, roughly. This year they're saying there could be a sitting in January and a sitting in February. And by the end of November, they'll confirm once they know how many people have applied. Because because the applications close on the 21st of November. So they'll know exactly how many have they got and how many of those, because not every specialty uses the MSRA, so how many slots do we need? And then they'll be able to say, okay, we're going to have to do, it's likely there's going to have to be 2 sittings to accommodate everyone. So, there's people that think, okay, right, I know I'm going to have to sit it roughly then. And even before they've applied, the same time they're working on their portfolio, they just start early preparing for the MSRA. I think that's a really good strategy, especially if, you're working and you might have to contend with a busy rota. By the time people are applying for specialty training, often some people are maybe starting a family, they've got other responsibilities. So they're just mindful of that. And they think, it's not like I can do several hours every day. I've got to start early so that I can fit it in. And then they just get on with it and they're consistent. I think that's a really good strategy. So starting early. Then there's people who they will wait until they've submitted their application. And then it'll be like, okay, I just want to focus on the application. Now I'm going to start. Of course, by that time, they've got less time to prepare. And if it was just a pass-fail exam, they've still got time to pass. But nearly everyone passes, especially for radiology. You could have a great score. 550 is an excellent score, right? But last year, 550 wasn't enough. And so, the less time you give yourself, because it's competitively ranked, it's not just about your absolute score. It's your score compared to other people in that year. Then there's people who wait until they actually get the invitation to book MSRA. Now, last year, that came around the 14th of December. By that time, there were only 3 weeks to the exam. You almost certainly haven't got enough time to prep well enough to get one of the scores that you need to get into a really competitive specialty like radiology. So I think one of the biggest things I would say is start early. So certainly anyone listening now, if you haven't already started, start today. Don't wait till tomorrow. Don't wait till next week. Don't wait until you get that email confirming that you've been longlisted or the email confirming actually you can book the exam. Just start. Because it's competitively ranked, even if you do really well, if there's one more slot for interview, one person gets 1 mark more than you, they might get that. And then now you don't have that chance to let your portfolio shine and show how well you can do at interview. I think that's one thing, is to start early, especially for the clinical, because the curriculum is large. They're not testing membership level knowledge about one specialty. What they're testing is that you've got a broad knowledge across kind of all the different specialties. So if I just go over what's in the curriculum, if you like, the clinical, they basically split it into 12 blocks. And, you can download the MSRA blueprint and it shows you this. But to give you an idea, there'll be about as many cardiovascular questions as there will be dermatology, ENT, and ophthalmology combined. Because dermatology, ENT, eyes is 1 block in the curriculum of 12, whereas cardiovascular is 1 block. Infectious disease, hematology, immunology, allergies, genetics, all of those combined is 1 block. Okay? Renal and neurology is 1 block. Pediatrics is 1 block. Gastroenterology and nutrition is 1 block together. Pharmacology and therapeutics is 1 block. Psychiatry and neurology, they've combined them together as 1 block. So, there's these different curriculum areas. So you want to systematically work through consolidating your knowledge and practicing questions. I think for the clinical, that's probably the mainstay, is that, going through lots of questions that are realistic, that are in the same format as a real exam. So in the clinical paper, there are 2 main formats. Extended matching questions, they come in sets, and they can have sort of a lot of answer options, sometimes 10, 11, 12 answer options, and then single best answers. So these are, each one's on one topic, and it's common for them to have 5 answer options. A lot of people are used to best of 5, but the single best answers in the MSRA, sometimes they'll have more. They'll have 6 or 7 answer options to pick from. So just allow enough time, do a mixture of practicing questions and reading up about the topics that, because let's say someone has been working one specialty for a long time. So actually, at the time that I applied for GP training, before GP training, I did orthopedics for a couple of years. Then I was doing a master's in informatics because I was going to leave clinical medicine. Towards the end of that, I needed a job because I didn't have to attend anymore. I was doing my dissertation. I needed a job to pay the bills. So I took a full-time job at a hospice in palliative care. And I fell back in love with clinical medicine. So, I've got quite a varied background. But because I hadn't done like peds since medical school, it's important that you don't forget to read that, because especially if someone's been in one specialty for a long time, you have to remember that they are testing that you've got a basic level of knowledge about all of these different subjects. So it's breadth rather than depth that they're testing.
Yeah.
And that's what makes it challenging. So allowing enough time so that you can sort of systematically cover everything by practicing questions and then reading up on the topics that you get incorrect. And then beyond that, I think doing at least a few full-timed mocks for the clinical paper, so you get used to managing your time, because 97 questions in 75 minutes, that's just over 45 seconds a question. So it's quite tough. A lot of people find it a little bit tight. So I think practicing your time management, covering the curriculum, allowing enough time, I think that's for clinical really, really important. For the SJT, it's a lot more about technique. So there is some knowledge that you need. The knowledge isn't clinical. You do need a good working knowledge of the updated good medical practice. So again, that was recently updated. They will use the 2024 good medical practice as the basis. There were some significant changes compared to the old version, which by this stage, the last one had been updated. It had been like more than a decade. So there's some big changes. So that is important. But ultimately, what happens in the SJT, you're giving a scenario, and what they're assessing is, do you demonstrate positives or negatives for those three domains: empathy and sensitivity, professional integrity, coping with pressure. Each of those domains is broken down into subdomains. So I think having a good understanding of what the subdomains are. So when you're reading a question, you can see, okay, I can see this is predominantly testing this domain, and this shows more positives compared to this option. That's why it's better. Or these go against this GMC guidance. So it's definitely not going to be part of the best response if you're having a selection question. So I think understanding the difference between section 1 and section 2, because the way they're marked and how you need to approach it in terms of your mindset is very different. And so I think that's a big part of the technique. And time management. The SJTs are also very time pressured. So I think if you can master those techniques, so if you get it wrong, you understand why you got it wrong and why the best answer is. After that, then practicing realistic questions will help you. Whereas one thing I do see sometimes is some doctors find the SJTs really challenging, because if you haven't understood the concepts of how to approach them, then if you just do lots of questions, you often find that your score doesn't improve that much, because it's not like clinical. Clinically, if you do thousands of questions, over time, you start seeing the patterns, you learn the content, right? Whereas the SJT, because it's not always like, it's judgment, right? It's not like maths, 2 plus 2 is 4. That's black and white. And that's why, especially for section 1, even if your answer isn't perfect, your answer can be close to the best response. You can actually get sometimes the wrong answer and get 90% of the marks.
Yeah.
And so that's a big part of the technique, is understanding how it's marked, mapping back to the domains, but also being able to put GMC guidance into context and actually see where it's relevant. So all of that's part of the strategy. And I think the other thing is to remember that in terms of the initial ranking, the two papers are equally weighted. Because one thing that I see sometimes is someone's got a brilliant clinical score, but they get a poor score in the SJT, and overall, therefore, they don't make the cut. Or vice versa. I've seen it the other way, that sometimes people are naturally good at SJTs, and then they spend some time improving it further, but they just didn't allow enough time for clinical. And so, and maybe they've been working in one specialty for a long time, they just haven't covered at all renal or urology. They haven't covered at all reproductive, or they just haven't covered dermatology, ENT, eyes. Some of the things that if you're not working in that specialty, you might not have seen since medical school.
Exactly, yeah. No, I think two things you've really nailed in that answer, Mahib, was, I just want to reiterate for those listening, is number one, the best day to have started was yesterday. The second best day to start is today. And those three categories of candidates is spot on. We get this year upon year. Okay, Mohammed, I'm just focusing on portfolio at the moment. I'm like, please don't neglect the MSRA. Don't neglect the MSRA. Then they get the invite. Like, now I've started MSRA. It's like, well, good luck, in the sense that we wish you all the best, but you've not really given yourself the best chance. The second thing is the curriculum. I think a lot of candidates who are currently, like, say, for example, an SHO in surgery, or like a IMT1 now applying for something else, they often have this element of saying, no, it's okay. I will be good at the medical. And I always tell them exactly what you said, Mohib, is like, okay, but when was the last time you did peds? When was the last time you looked at the immunization schedule? Probably medical school finals, and that's it. And not only is medicine rapidly changing, but when you actually sit down with the curriculum, you realize it is a step above medical school finals in the sense of, as you hit the nail on the head, Mahib, it's breadth of content. And if you don't give yourself enough time, that breadth can really take your breath away because it's so overwhelming. And you don't want to open it up. See, your first question is ophthalmology, differentials of the red eye, and you're like, oh crap, I've left this too late, because it will just demotivate you. And I really like the way you said about the strategy. Clinical is about the amount of volume in sense of getting through questions, but SJT is strategy. And a lot of candidates, in my opinion, looking at the SJT, try to rote memorize, and they're trying to put a circle in a square peg. And because it just doesn't keep fitting in, or they use one resource that contradicts another resource, on the day of the exam, it's just going in blind, which often, as you said, they get comfortable with the clinical, and then they really undersell themselves in the SJT. So before we go into your top 3 tips for each section, let's start the converse. What are the top 3, let's say 3 pitfalls that you see in candidates every year that means candidates ultimately don't get the score that is reflective of their ability?
So number 1, leaving it too late. So just, delaying starting until, especially those that delay until they get the invitation. In almost every case, it's too late at that stage. Okay, you can still do your best, right? But you're just not doing yourself any favors. So starting early, the opposite of that is how you counteract that. Number 2, I think underestimating the exam, and there's 2 reasons that can happen. So one that you picked up, that yes, the curriculum is broad, but the level of it is harder than finals. It's not at membership level, but it's somewhere in between, because the level of the testing is the knowledge expected of someone who's in F2. So i.e., you've already been practicing making diagnoses, treating patients, dealing with emergencies. So it's a step up from finals, where they know that although you should know the theory by now, and you will have spent time on the wards, they know you've never actually prescribed something or actually, managed the patient entirely on your own, on an on-call. Okay, so it is a step up. So underestimating that way, but I think the other way is underestimating the competition. And sometimes what can happen is they'll talk to a colleague, and this is actually, generally, this is a good thing to do, is that if you're going to prepare for an exam, asking someone who did it before you, what did you find helpful? How did you prep? That's generally a good thing, right? And some of their advice in terms of resources they found helpful might be beneficial. But I think the thing that's different is they might have to talk to someone who maybe is in radiology and they're already in ST3, ST4. And the competition ratio and the level needed to get an interview when they were applying is very different. So they say, oh yeah, actually I did the application, and then I had 2 months and I just focused on that then. I didn't bother about it before. I didn't want to spend too long on it. And someone might already have a good knowledge base, and they already got a lot of familiarity with SJTs, because in those days, people were doing it as part of foundation, so they had some familiarity. In those days, 520 might have been enough to get an interview for radiology. And then, like, for example, the year after that, maybe 530, and then 54. Last year, 555. This coming year, it might be 560. So I think underestimating the goalposts shift, if you like, as to what you need. And that's the second one. And then the third one would be really making sure that you understand both papers are important. They're both equally weighted, and not just leaving. Sometimes what people do is they just do all their clinical, and the SJT is an afterthought. And they just, in the last couple of weeks, you should be doing both alongside each other. And then if you see, actually, I'm finding this a bit challenging, maybe you look for extra support with the SJT. Maybe for the clinical, it might be that if you allow enough time, you can cover everything. But if not, then at least you're strategic. Start with the things that you maybe haven't done for a long time. Never, but there's always something that everyone, like in medical school, I always found neurology really tough. So now, whereas I really love numbers, I mentioned I did a master's degree in informatics. I love stats. Okay. Now, there's no stats in this exam. Like in the membership exams for GP, there's a stats module. And like for me, I love to do, I'll do those questions all day because I like to see a good mark. I avoid the neurology ones. I don't want to see a low mark next to my name, right? I can see, like, for me, if I didn't do any stats, I'm probably going to be okay. If I'm going to do something, if I'm not going to have time for everything, then at least I should start with the ones I hate. Start with the ones that you haven't done for a long time. So I think those are the three things I would say.
No, I think those are excellent tips in the sense that the one which really resonated with me, I was just shaking my head quite vigorously there, was it's relative. Your score is not absolute in the sense that, okay, Mohammed, well done. You used EMedica, used the resources, and here you go. You got the pass score. You're in to interview. It's not that. It's okay. Mohammed's score was this. Mohib's score was here. So Mohib gets the interview. And Mohammed, even though you got above the pass mark, which, as Dr. Rahman said, is quite low in the sense what is a pass, it's not sufficient. And if the number of applicants is going up to like from 6 to 12 per seat for radiology, then the pool that you are being compared to is going to get higher and higher and higher. And if you do just a simple X and Y, we're talking about stats, my stats is atrocious, I would hate those questions, is you would just see a nice steep linear curve going towards a higher value. And that's projected probably is going to happen for the 2024-2025 recruitment cycle. And I think the last bit we mentioned is start with your weaknesses. It's a very medic mentality to like stick with your strengths, get those ticks on the question bank. But honestly, my weakest subject in medical school, and probably still now, thankfully I don't do it, is hematology. I hated it. I just didn't understand the anemias. I didn't understand why this is this and that. I was like, listen, I need to get to grips with this quickly, because once you get the high yield points, you quickly filter those and you like 45 seconds per question in a clinical. You don't have time to be trying to get it from first principles. But I always say that the best type of mentality to have for any exam prep is don't be scared of getting it wrong in your prep. It's better to get it wrong now than it is in the real exam. And I think don't be like, okay, I'm just going to focus on definitely what Mohib said is so spot on. Please don't put SJT as an afterthought. It always happens because people get told by seniors, oh, you can just, figure it out on the day. It's just common sense. That's what I hear a lot. It's just common sense. It isn't. It is strategy. There is method to the madness. And there are certain things you should know, like from a medical legal perspective. So please definitely don't give SJT an afterthought. So maybe you've kindly talked about the top 3 pitfalls and then told us how you would address those, like give yourself time, don't neglect your competition, don't neglect the curriculum. So with your role as the medical director of EMedica, can you just give an overview of the platform to the audience and what support they could receive using your resources?
Sure. Yeah. So, when we first started running courses to help people get into GP training, shortly after that, we started running courses 2005. And so then initially there were those white space questions. There was the sort of OSCE type simulated consultations. There was an essay paper and a group exercise. Then they moved to introduce the MSRA, and people were desperate for practice resources, like medics for any exam. If you're going to do finals, you want some practice papers. If you're going to do, your radiology exams, you're going to want some practice questions, right? But there was nothing. And I contacted the National Recruitment Office and I said, do you have anything? They were like, ask the Royal College. And they were like, oh no, this is new. We haven't got anything. And they sent me back. So I was like, okay, look, people are asking something. We should develop something. So, no one had actually seen, because it hadn't been run yet, what actual questions looked like. But they had a few samples on the Recruitment Office website, and they had the curriculum. So we just set up and made a very small question bank. It was only about a couple hundred questions at that point. But it was better than nothing, right? And people could at least practice. And then over the years, what we've done is, the question bank, when they made changes to the format, they introduced extended matching questions. They took out true-false questions. We adapted the introduction of the SJTs, the changes of the format. So over the time, what we do is we recruit people who've done really well each year to write original questions. We would never take any questions that were in the actual exam. You should never share actual questions from the exam. That's unprofessional. But if someone's done well, they at least know what the format is like and they know what the level is like and they've understood it. So then we will guide them to, we want questions on this topic so we can have broad coverage. So what we've done is our question bank, we've got the clinical questions mapped to those curriculum headings. So you can do it subject by subject. And there's like 30 questions in a block. So for example, cardiovascular 1, there's 30 questions on cardiovascular. Then you could do respiratory 1, 30 questions on respiratory. Then endocrinology and metabolic 1, 30 questions on that. And each one's got a concise explanation. Then once you've done one of all of them, go back. There's cardiovascular 2. That's the strategy I recommend. Rather than doing all your cardiovascular at the beginning, and then by the end, you forget the cardiovascular. You do a block of each of them, and there's like 3 for each one. Then there's timed mini mocks. Then there's timed full mocks. The timed mocks, you can do standard timing. For those that get extended timing, 25% extra time, for example, if you've got dyslexia or some other form of neurodiversity, so that you can practice with your actual timing. We have versions with that timing. And then we have it untimed if you just want to practice it. And then SJT. One of the issues for the SJT is the section 1, they're marked using something complex called keyed responses marking. There was no commercially available quiz making software that could emulate how it's marked in the actual exam. We searched, we contacted every provider. So in the end, we had to build our own. We hired a programmer and we said, this is what he wanted to do. And we built. And so ours looks just like the real thing in terms of like section 1, you're actually dragging, but it marks exactly the same way as the real thing. So you can get used to and understand how it will be marked. So we've got 2,200 questions, 2,000 clinical to cover the curriculum, about 200 SJTs. There's full-timed mocks for both papers, all included in our question bank. And then for those that maybe either just want to do something that will give them a little bit extra, or maybe they've sat it a couple of times and they've got a good score, but they just, again, for something really competitive, they need a little bit of extra juice, or they struggle with the technique. We have a 2-day MSRA cram course, so a full day on clinical, cover about 100 clinical topics, the current updates to the guidelines. You can cover a lot of material quickly. If you've left it late, for example, can let you cover things that might have taken you several weeks to read each guideline. We've summarized them and, we get you used to the timing. We cover what are the different keywords, how to spot them, how to apply them to separate down and narrow the options. And then a full day, the second day, the full day is on the SJT. So we'll cover the updates and the key sort of GMC ethical guidance, capacity, confidentiality, edit competence, when you can and can't accept gifts, things like that. But we'll also look at what are those 3 domains, what are the subdomains, how to spot them, the difference in mindset from section 1 and section 2. We'll do timed high-yield questions, a timed mock exam, and then go through detailed discussion. So you understand, why did I get it right? Because sometimes you get it right by, like if you guess, you might still get it right. But you can't then apply the principles to the next one because it was a lot. But if you understand, why did you get the ones right? Why did you get the ones wrong? And why is the right answer? By the time we've done that, we go through like 40 scenarios in depth, it clicks. And then the 2-day course also includes all the questions in the question bank. It includes access to the recording of the full 14 hours, 7 hours teaching on day 1, 7 hours on day 2. So you can watch it back to revise any bits. You've got the course booklets as a PDF, but then you also have access to the questions until the end of February, in case you get allocated to the February slot. I'd say people that, like some people, if they've already started, they're already finding that, they've covered a good amount and they're getting good scores, they have a good handling on the SJT. It may well be that doing our question bank, and then if you've got time, another question bank, so you get exposed, especially as I mentioned for clinical, the more questions you do, the more it sort of clicks. I think that might be plenty. I think for people that might maybe either have left it a bit late, or they're doing well, but they're applying for something really special, competitive, like radiology, and they're limited to the areas. So actually, they need to be absolutely sure that they get that interview because, they're only going to be considering a few places. And then people that maybe had wished they'd started, but sometimes things come up and you couldn't start, his family member was unwell. And so you just want to be efficient. You want to cover a lot of ground in a short amount of time. I think they're the people that the course would particularly be helpful for.
Fine.
So they're the
When
things
is
that,
the
well, look,
2-day crammer course? Mahib?
so it's the Saturday the 30th of November and Sunday the 1st of December. So that after the course, especially for the SJT, for a lot of people, it changes their mindset and approach.
Mm,
But also for the clinical, once you understand some of the keywords, you will
exactly.
have already done some questions before. But after that, what you'll find is when you do more questions, you have a better approach. And it will hopefully help you also. Sometimes people get a bit fed up of study. So
Mm,
it will give you motivation to just keep going and give you that boost for that last period of, could be a month and a bit if you're at the January sitting, could be 2 months to the run up to the exam.
February.
Yeah. One other thing that we have is, like if people are looking to cover guidelines that are up to date, you could go to the NICE website, and if there's a specific topic, that's a great resource to look at it. If you want to cover lots, because NICE guidelines can be quite long,
Yeah.
it's not always possible to read them. So a lot of people have had the same issue. So we do have a printed resource, our clinical case cards. So our team basically got together and looked through different guidelines and topics, and we sort of made, and some of them aren't specific, like this is the WHO pain ladder. We've got how to deal with febrile seizures, for example. We've got different types of alopecia, and where relevant, we've licensed high quality images, and so there's 112 topics,
Wow.
and they're mapped to the kinds of things that questions are about in the exam. So some are about investigations, some are about the key features to make a diagnosis, some are about the current guidelines for management. So they've been updated in 2024. So there's a digital edition, or there's printed ones available in the UK. So these are
No,
the
I
things
think
that we have. And also people can contact us often if they've got questions about things like, their CREST form or eligibility to apply, things like that, because we're helping so many people each year.
yeah.
We've been asked so many questions, and those that a lot of people ask, I contact the recruitment team and get directly what is their guidance. So we often can give a definitive answer.
No, I've seen you very active on the Facebook groups. I know EMedica have their own Facebook group, and we get asked about CREST form. I just put my hands up and say, I'm really sorry, I don't know that, and I don't want to give you the wrong information. Often I say, please go on the EMedica Facebook group. Dr. Rahman is very active. He knows a lot more about these other supplementary elements, Oriole, CREST form, eligibility criteria, ranking even, which is also part of your application, not just the MSRA. There is a lot of more hogs within the application. One thing I would say to candidates applying this year is, if you're thinking about London as a place of work, just know your expectations are higher than other trainees, because London, for all specialties, I cannot think of one where it's less competitive. London is notoriously more competitive, whereas the academic clinical fellowships in London or a standard clinical training program in London, for example, radiology, it's just more competitive. And you have to kind of have dotted your I's, crossed the T's in terms of your prep, because you just have to have a higher score than other candidates. That's just expected of you. The second thing is, this year there's been a lot of changes across a lot of things, notably the good medical practice, which is, as Mahib said, after a decade, just updated. And they will not be like, oh, it's okay, you haven't had time to read it. They're like, no, we expect you to know now what the 2024 criteria of being a good medical practitioner is, and then apply those rules. So these kind of crash courses, these high yield courses, can be very useful in consolidating your knowledge and quickly identifying your gaps, where you can be like, okay, I've got a month left before the January sitting, or 2 before the February. I really need to get to grips, for my case, iron deficiency anemia, because I hated hematology. Now, before we finish, of course, we've talked about the MSRA can at times get a bit doom and gloom. Everyone's like, oh, panicking. That's not the point of this podcast, this episode. The whole point of these type of resources is that you can get insight into where you are and where you need to be through not only experts like Mahib, but through speaking with your peers, of course. And always we like to end on a positive note. So with that being said, Mahib, what's the best success story you've come across during your time with EMedica? Like a story that you think could inspire those listening in?
I think while this is for someone applying for a different specialty, I think that it's really relevant to radiology because of the level of competition. But I'll give you two that really stand out. So, there's people who plan ahead and they work really hard and they've already got a very good knowledge base. And even whether they came to our course or not, they were already going to do well, but maybe it helped them to squeeze a bit extra. So they're always going to get a job, but it helped them get their first choice job. I think the things that inspire me the most are people that had adversity and overcome it. So there was someone who, if I read out their feedback, okay, that just the last bit, that basically they sat the MSRA 2 years previously. They got into obstetrics and gynecology. They had a 520. And that was enough to get an interview, and then they did really well at the interview. But then sometimes it doesn't work out.
Yeah.
For various issues, they decided to leave obstetrics and they applied to GP and they contacted us. They came on the course and they realized that now they wanted to stay in a specific area. Often by this stage in training, you might have set down routes and so on. Now, if you want to stay in a specific area and you're only ranking a few localities, you need a brilliant score. And so there was someone that already was doing very well. Okay. That had a 540 before, not a 520. So 540 is an excellent score.
Yeah.
But they still were willing to do, because they wanted to make sure they got like one specific area. They went from 540 to 610. That's a 70 mark increase. And at that higher end, that's actually much harder than, it's much easier to add 70 if you're high 400s than it is when you're already at a high score like that. And then there was someone else who went, it was a 73 mark increase. They went from
73
mid 550s or something like that to like 620 something. But I think just being willing to not give up, and that I find that really inspiring, because a lot of people might think, I've done everything. This is already a good score. It's just, the competition is too much, and give up.
Yeah.
Whereas if you're willing to, and I think that really, you mentioned about finishing on a positive. I think I'd say two things. Michael Corder said, to succeed, we must first believe that we can. Radiology is very competitive, but somebody's going to get that job, right? Have it in your mind, it's going to be me. But if you have that in your mind, I can do it, but I accept it's competitive. That's the reality. Don't worry about things you can't change. That's not in your control, the level of competition. What's in your control is how much work do you do? When do you start? So hopefully you've already started. If you haven't, start now, okay? Do something every single day, consistently. You're going to have to make some sacrifices, okay? Christmas is coming up just before. Maybe there'll be like people going out for dinners and things like that. I'm not saying don't be social, but maybe you say, look, I'm going to do a bit of study and then I'll join you for dessert. Maybe sometimes, again, there's scheduled teaching time. And sometimes coming up to Christmas, they cancel it. And you think, oh, great, it's cancelled. I'll go shopping. Don't go to the library. Do some more questions. Get your books out. Do what you have to, because it will be worth it in the long run. These few months of sacrifice, you've got your whole career. It gets you maybe where you want or the area that you want. And then the last bit is what Malcolm Shabazz said, that the future belongs to those who prepare for it today. So once you have that mindset, I can do it, but I know it's hard. Just be willing to do the work and just be consistent. And if you've done all of that and it's still not enough, remember that not getting in isn't the end of your story unless you choose to make it so. Like this person, they had a great score, but they managed to say, okay, I'm going to work on it. I'm going to do anything I can. I'm going to go for it again. And then they worked on their portfolio. Their portfolio was improved by the next year as well. But then they squeezed from, 550 to 625, or from this person 540 to 610. So if they can do it, you can do it. To get this far in your career, you're already shown that you're talented, you're intelligent, you're motivated. Don't give up. Have in your mind, I can do it. Yes, it's hard. Radiology, you're picking a competitive specialty, but you've got this far. You can do it. You've just got to do the work. And if you need support, there's support out there. So, feel free to contact me. You can contact me on Facebook. You can find emedica.co.uk is our website. Our email's on there. Feel free to drop me an email if you've got any queries. But, support is there if you need it. But whether you come to one of our things or not, I genuinely wish you every success. Okay, prepare and you will succeed.
I think you've inspired me to sit the MSRA. I don't need to. Thankfully, I don't need to. But thank you again, Dr. Rahman. One interesting thing, I don't think you know this. I didn't tell you this beforehand, so it's a bit of like sharing today. I actually, when I applied, and this is not fake or just making it up, I went to your grammar course. Your 2-day grammar course at that time, 2018, 2019, it was face-to-face. I went to the one in Manchester, and it was information like high yield. Everything was high yield because I remember you starting your session every day. You said, listen, you're all going to leave exhausted. You're all going to leave tired, and you're going to leave like you've condensed a lot. But this is the high yield knowledge you need to have for this specialty. That's subdomain respiratory. Do you know your asthma guidelines? For electrolyte imbalances, hyperkalemia, hypokalemia, do you know the ECG changes? And I remember leaving not only solidifying things I knew, but realizing things I didn't, which was very critical because it was the same time period. January was the MSRA, but I had that month where I could be like, okay, I really struggled with understanding Gillick competence. I just don't get it. I need to go away, read about it, come back and attempt these questions. And honestly, like for me, I was that candidate who prepared early because I knew what I was getting in store for. It was the cherry on top for my prep. I'd built up my knowledge and then sat it, condensed everything that I knew, identified things I didn't know, and then I could go away. For others who, as you said, may be having other elements contributing towards their revision, it can be the jet fuel to your revision. Be like, okay, this is what's expected of me. Here we go. And then supplement it with the online resources. Now, of course, we work together, collaboration. You've kindly offered a discount code for our audience, which is RadCast, all lowercase. And as part of that, you will get 10% discount to the MSRA question bank, the online resources. And you've kindly offered those who use the discount code RadCast a £25 discount for the live 2-day MSRA grammar course. So when again was the MSRA grammar course?
30th of November and the 1st of December. So it's a Saturday and a Sunday. It's a full weekend, 9:30 a.m. to sort of 6:30 p.m. each day. So they're long days. And like you said, you will be exhausted, but that's why you'll be able to access the recording for a month afterwards so that, you can then watch it back as many times as you want, or maybe some parts of it. There might be some parts that you think, oh, actually, Gillick and Fraser, I always struggle with the difference between these. Let me watch that part again, or just the GMC guidance. Let me look at it again, or let me look at these clinical guidelines that we covered from the MOP. Let me look at those bits again. They're in modules, so you can watch each module or the whole thing as many times as you want.
And of course, the website for EMedica is emedica.co.uk. All the resources will be there. You can just go through the website, book if you want to. Remember the discount code RadCast, all lowercase. So thank you again, Dr. Mahibur Rahman. Excellent resource. Make sure to like and subscribe to the YouTube channel, and we'll see you on the next episode. Take care, everyone.
Thanks very much, Mohammed. And
thank you.
All the best to all of your listeners.
Thank you very much.